Good afternoon, dear students. We continue our lectures, and today's topic is pneumonias. Pneumonia results from the proliferation of microbial pathogens at the alveolar level and the host response to those pathogens. Microorganisms gain access to the lower respiratory tract in several ways. The most common is by aspiration from the oropharynx. Small volume aspiration occurs frequently during sleep and in patients with decreased levels of consistence. Many pathogens are inhaled in contaminated droplets. Rarely, pneumonia occurs via hematogenous spread or by contagious extension from an affected pleural or mediastinal space. Mechanical factors are critically important in host defense. The hairs and turbinates of the nares capture larger inhaled particles before they reach the lower respiratory tract. The branching architecture of the tracheobronchial tree taps microbes of the airway lining, where mucociliary clearance and local antibacterial factors either clear or kill the potential pathogens. The gag reflex and the cough mechanism offer critical protection from aspiration. In addition, the normal flora adherent to mucosal cells of the oropharynx, whose components are remarkably constant, prevents pathogenic bacteria from binding and terribly decreased the risk of pneumonia caused by this more virulent bacteria. When these barriers are overcome, or when microorganisms are small enough to be inhaled to the alveolar level, resident alveolar macrophages are extremely efficient and clearing and killing pathogens. Macrophages are assisted by proteins that are produced by the alveolar epithelial cells and that have instinct opsonizing properties or antibacterial or antiviral activity. Once engulfed by the macrophage, the pathogens, even if they are not killed, are eliminated via either the mucociliary elevator or the lymphatics, is no longer represent an infectious challenge. Only when the capacity of the alveolar macrophages to ingest or kill the microorganisms is exceeded, does clinical pneumonia become manifest. In that situation, the alveolar macrophages initiate the inflammatory response to boost the lower respiratory tract defenses. The host inflammatory response, rather than proliferation of microorganisms, triggers the clinical syndrome of pneumonia. Inflammatory mediators released by macrophages and the newly recruited neutrophils create an alveolar capillary leak equivalent to that seen in the acute respiratory distress syndrome. Also, in pneumonia, this leak is localized. Even erythrocytes can cross the alveolar capillary membrane with consequent hemoptysis. The capillary leak results in a radiographic infiltrate and raise detectable on auscultation, and hypoxemia results from alveolar filling. Moreover, some bacterial pathogens appear to interfere with the hypoxemic vasoconstriction that would normally occur with filled alveoli, and this interference can result in severe hypoxemia. Increased respiratory drive in the systemic inflammatory response syndrome leads to respiratory alkalosis. Decreased compliance due to capillary hypoxemia, increased respiratory drive, increased secretion, and occasionally infection-related bronchospasm all lead to dyspnea. If severe enough, the changes in lung mechanism secondary to reduction in lung volume and compliance, and the intrapulmonary shunting of blood may cause respiratory failure and the patient's death. Classic pneumonia involves through a series of pathologic changes: edema of tissue, presence of proteinaceous exudate, and often of bacteria in alveoli. Clinically is not distinguishable. Second, red hepatization, presence of erythrocytes in the cellular intraalveolar exudate, neutrophil influx, bacteria are occasionally seen. Third, gray hepatization, no new erythrocytes are extravasating, and those already present have been lysed and degraded. The neutrophil is the predominant cell. Fibrin deposition is evident, and bacteria have disappeared. And the fourth, resolution. The macrophage reappearance as the dominant cell type in the alveolar space, and the debris of neutrophils, bacteria, and fibrin. Types of pneumonia. There are bronchopneumonia, lobar pneumonia, and interstitial pneumonia. Bronchopneumonia affects one or more lobes, being frequently bilateral and basal. Microscopically, one can identify multiple foci of condensation, white, yellowish, imprecisely circumscribed the center by bronchiole, separated by normal lung parenchyma. Lobar pneumonia is a radiological and pathological term referring to homogeneous consolidation of one or more lung lobes, often with associated pleural inflammation. Interstitial pneumonia is a pneumonia that affects interstitial tissue of the lungs. Typical lung findings is unusual interstitial pneumonia. Fibrosis of both lobes can be seen with honeycomb change involving primarily the lower partition of the lobes. Usual interstitial pneumonia with an abrupt transition from honeycomb change to normal lung. Especially homogeneous pattern of fibrosis seen in non-specific interstitial pneumonia. Clinical presentation. A patient should be suspected of having pneumonia when one of the following signs and symptoms are present: new focal chest signs, dyspnea, tachypnea, pulse rate more 100, or fever or more 4 days. The classical physical findings in lumbar pneumonia include evidence of consolidation with altered transmission of breath sounds, endophony, bronchial breathing, and whispering pectorility. Cracks, crackles, scattered bronchi, capitation redux, and indux. Changes in tactile phragmics. Pleuritic pain. When consolidated, the lung is typically dull the percussion. Diagnosis. What general investigation should be done in a patient admitted to hospital? Oxygenation, saturations, and where necessary, arterial blood cases in accordance with the BTS guideline for emergency oxygen use in adult patients. Chest radiograph to allow accurate diagnosis. Urea and electrolytes to inform severity assessment. C-REACTIVE protein to aid diagnosis and as a baseline measure. Full blood count, liver function test. X-ray findings, lobar pneumonia. There is homogeneous opacification in a lobar pattern can be sharply defined at the fissures. Also, more commonly, there is segmental consolidation. The non-opacified bronchus within a consolidated lobe will result in the appearance of air bronchograms. Strictly speaking, consolidation is not associated with volume loss. However, atelectasis can occur with small airway obstruction. Bronchopneumonia, multiple small nodular or reticulonodular opacities, which tend to be patchy and or confluent. These represent areas of lung where there are patches of inflammation separated by normal lung parenchyma. The distribution is often bilateral and asymmetric and predominantly involves the lung bases. Interstitial pneumonia. Ground glass opacities combined with irregular linear or reticular opacities can be normal in early stages. There may be ill-defined or ground glass opacities with lower lobe distribution or consolidation in a patchy, reticulonodular or mixed pattern. A bilateral pulmonary infiltrative pattern may be seen in those with advanced disease. When should a chest radiograph be performed in hospital? All patients admitted to hospital with suspected CAP should have a chest radiograph performed as soon as possible to confirm or refute the diagnosis. The objective of any service should be for the chest radiograph to be performed in time, for antibiotics to the administered within 4-6 hours of presentation to hospital should be diagnosis of CAP be confirmed. When should the chest radiograph be repeated during recovery? The chest radiograph need not be repeated prior to hospital discharge in those who have made a satisfactory clinical recovery from CAP. A chest radiograph should be arranged after about 6 weeks for all those patients who have persistence of symptoms or physical signs, or who are at higher risk of underlying malignancy, especially smokers and those age more than 50 years. Whether or not they have been admitted to hospital. CT findings pneumonia, lobar pneumonia can have has a pattern of focal ground glass opacity in a lobar or segmental pattern. This is due to incomplete filling of alveoli and consolidation. At other times, there can be dense opacification of the entire lobe. Bronchopneumonia. Multiple foci of opacity can be seen in a lobular pattern, centered and centrilobular bronchioles. This may result in a three-in-bud appearance. These foci of consolidation can overlap to create a larger heterogeneous confluent area of consolidation or patchwork coiled appearance. Interstitial pneumonia. Ground glass opacities combined with irregular linear or reticular opacities. Reticular opacity sometimes mean subpleural reticulation. Thickening of bronchiovascular bundles with NSIP with fibrosis. Why are microbiological investigations performed? Microbiological tests should be performed on all patients with moderate and high severity CAP. The extent of investigation in this patient being guided by severity. For patients with low severity CAP, the extent of biological investigation should be guided by clinical factors, age, comorbid illness, severity indicators, epidemiological factors, and prior antibiotic therapy. Where there is clear microbiological evidence of a specific pathogen, empirical antibiotics should be changed to the appropriate pathogen-focused agent unless there are legitimate concerns about dual pathogen infection. Examination of sputum should be considered for patients who don't respond to empirical antibiotic therapy. Examination of sputum for Mycobacterium tuberculosis should be considered for patients with a persistent productive cough, especially if malaise, weight loss, and or night sweats or risk factors for tuberculosis. Etiologic diagnosis. Gram stain. Microbiological tests such as cultures and gram stains are not recommended as primary care. Gram stain differentiates between organisms with thick peptidoglycan cell walls and those with thin peptidoglycan cells walls and outer membranes that can be dissolved with alcohol or acetone. Gram stain is particularly useful for examination sputum for polymorphonuclear leukocytes and bacteria. Sputum analysis. Sputum samples should be sent for culture and sensitivity tests from patients with CAP of moderate severity who are able to expectorate purulent samples and haven't received prior antibiotic therapy. Culture of sputum or other lower respiratory tract samples should also be performed for all patients with high severity CAP or those who fail to improve. Sputum cultures for Legionella should always be attempted for patients who are Legionella urine antigen positive. Legionella culture should be routinely performed or on invasive respiratory samples from patients with CAP. Even in cases of proven bacteremic pneumococcal pneumonia, the yield of positive cultures from sputum samples is less than 50%. Etiologic diagnosis. Blood cultures. Two sets of blood cultures from two different veins should be performed in all patients with CAP who require hospitalization before antibacterial treatment prescription or 10 days after the last dosages of antibacterial drug. C-reactive protein is the most common laboratory marker used in the clinical setting to evaluate systemic inflammatory response to a bacterial infectious agent. CRP is an annular pentametric protein found in blood plasma whose levels rise in response to inflammation. It's an acute phase protein of hepatic origin and increases following interleukin-6 secretion by macrophages and T cells. Its physiological role is to bind to lysophosphatic dicholine expressed on the surface of dead or dune cells or dying cells in order to activate the complement system via the C1q complex. CRP is synthesized by the liver in response to factors released by macrophages and fat cells. CRP binds to the phosphocholine expressed on the surface of dead or dying cells and some bacteria. This activates the complement system, promotion phagocytosis by macrophages, which clear necrotic and apoptotic cells and bacteria. In patients with a suspected pneumonia, a test for serum level of C-reactive protein can be done. A CRP level of less than 20 milligram per liter at the presentation with symptoms for more than 24 hours makes the presence of pneumonia highly unlikely. A level of more than 100 milligrams per liter makes pneumonia likely. Classification of pneumonia. Community acquired pneumonia is that which occurs in the absence of immune compromise or prior hospital admission within the previous 30 days. Hospital acquired pneumonia or nasal pneumonia can occur in anyone resident in hospital for more than 48 hours. Ventilator-associated pneumonia hospital common in the intensive care unit more than 48 hours after endotracheal intubation. Pneumonia in the immunocompromised and aspiration pneumonia in those with swallowing impairment and neurological impairment. Community acquired pneumonia includes cases of infections pneumonia in patients living independently in their community. Patients who have been hospitalized for other reasons for less than 48 hours before the development of respiratory symptoms are also considered to have community-acquired pneumonia. Risk factors for CAP. Cigarette smoking, upper respiratory tract infections, alcohol, corticosteroid therapy, old age, recent influenza infections, pre-existing lung disease, HIV, indoor air pollution. Typical CAP pneumonia. The pneumococcus accounts for 50–80% of community-acquired bacterial pneumonias. Types 1 to 9 and 20 are most commonly found in adults. Essentials of diagnosis: sudden onset of shaking, chills, fever, chest pain, and cough with rust-colored sputum. X-rays show infiltration, often lobar in distribution, but sometimes patchy. During resolution of the consolidation, which may require 8 to 10 weeks, areas of radiolucency may appear, suggesting pseudocavitation. Pneumococci are present in the sputum and often in the blood. Leukocytosis. Typical sputum from pneumococcal pneumonia contains many red and white cells and many pneumococci. Staphylococcal pneumonia. Pneumonia caused by Staphylococcus aureus occurs as a sequela to viral infections of the respiratory tract and in debilitated patients. A history from a mild illness with headache, cough, and generalized aches that abruptly changes to a very severe illness with high fever, chills, and exaggerated cough with purulent or blood-streaked sputum and deep cyanosis. The diagnosis must be confirmed by stains, smear of sputum, and culture, and also by means of culture of pleural fluid and blood. X-ray examination reveals lung consolidation, pneumocells, absence, empyema, and pneumothorax. The demonstration of biopneumothorax and of cavities with air fluid levels, Staphylococcus aureus. The diagnosis of MSSA, community-acquired pneumonia, is based on the clinical presence of fever more than 39, cyanosis, tachycardia, hemoptysis, hypertension, rapid cavitation on infiltrates on chest radiographs, plus MSSA in respiratory secretion, risk factors, cardiopulmonary disease, alcoholism, or diabetes. A typical CAP pneumonia. The eponym Legionello's disease has been given to a serious pneumonia that afflicted people attending the American Legion Convention in Philadelphia in 1976. Other outbreaks have been diagnosed retrospectively at least since 1965, and sporadic infections have occurred at least since 1947 in many places. Legionella species occur in the environment and are acquired by humans from aerosols, dust from air conditioning systems, water, or soil. The incubation period is estimated to be 2 to 10 days. Initial symptoms are malaise, diffuse mild chills, and headache, followed in 20-48 hours by high non-remittent fever and chills. Nausea, vomiting, and diarrhea are frequent early in the illness. On the third day, a dry cough begins that is non-productive or produce scantily mucoid, sometimes blood-streaked sputum. Dyspnea and hypoxia become marked as signs of consolidation develop. Pleuritic chest pain occurs in 1/3 of patients. Severe confusion or delirium may occur. We can see on chest X-ray patchy, often multilobar pulmonary consolidation, and occasionally small pleural effusion. Mycoplasma pneumonia is a common cause of community-acquired pneumonia, and the disease usually has a prolonged gradual onset. Mycoplasma pneumonia was first isolated in cattle with pneumonia in 1898. PCR of respiratory tract samples such as sputum should be the method of choice for the diagnosis of mycoplasma pneumonia. The patient's history may include the following: a fever, generally low grade, malaise, headache, persistent, slowly worsening, incessant cough, scratchy sore throat, wheezing, mild pharyngeal injection with minimal or no cervical adenopathy but no exudate. Normal lung findings with early infection but raunchy rails and wheezes several days later. Mycoplasma pneumonia. Diffuse consolidation and and hemorrhage in both right and left lungs, most severe in the bilateral upper lobes and right middle lobe, mycoplasma pneumonia. Chlamydia pneumonia, the incubation period is approximately 3-4 weeks. Symptoms develop in a biphasic pattern characterized by an initial period and of upper respiratory tract symptoms, followed by symptoms of pneumonia after 1-4 weeks. Fever is present in the first several days, less often after 1 week. Cough is prominent with scant sputum production and may persist for weeks, 2 months. Chest X-ray, a single subsegmental infiltrate that is mainly located in the lower lobes. Viral causes viral pneumonia. There is 27% of cases are mixed bacteria virus. 4 most common viruses encountered: influenza virus, respiratory syncytial virus, adenovirus, para-influenza virus. Respiratory viruses multiply in the epithelium of the upper airway and secondary infect the lung by means of airway secretion of hematogenous spread. Respiratory viruses damage the respiratory tract and stimulated the host to release multiple humoral factors, including histamine, leukotriene, C4, and virus-specific immunoglobulin E, bradykinin, interleukin-1, interleukin-6, and interleukin-8. Chest X-ray, bilateral lung involvement, influenza, and peribronchial infiltrates, RSV pneumonia, patchy bilateral alveolar infiltrates, and interstitial changes, adenovirus pneumonia, bilateral and patchy ground glass infiltrates with preference for lower lobes. Principles of antibacterial treatment of pneumonia. Antimicrobial treatment has to be empirical and should follow an approach according to the individual risk of mortality. The next is aspiration pneumonia. Aspiration pneumonia should be considered in patients with difficulties with swallowing who show signs of often acute LRTI. In these patients, a chest X-ray should be performed. Predisposing factors include impairment of the swallowing mechanism, inadequate cough reflex, impaired gastric emptying, when should aspiration pneumonia be suspected? In those with CAP, which either first follows an episode of witnessed aspiration, or second occurs of the presence of risk factors for aspiration. Traditionally, posterior, anterior, and lateral chest radiographs have been recommended for imaging aspiration pneumonia and its complications. Computer tomography scanning is the best method for diagnosing aspiration pneumonia and abscess or an MPMO. CT scanning uh, sorry, CT scanning precisely defines the location of the lobar of segmental opacity, a foreign body in the tracheobronchial tree, and associated atelectasis or consolidation can be defined with relative on CT scans. Magnetic resonance imaging is more sensitive than plain radiography. The patient's following mechanism can be studied by using fluoroscopy with a contrast agent in real life. Radionuclide salivagram can demonstrate the aspiration of saliva. Salivograms can document salivary aspiration and the source of recurrent pneumonia. Hospital acquired pneumonia is pneumonia that occurs 48 hours or more after admission and did not appear to be incubating at the time of admission. Healthcare-associated pneumonia is a bacterial infection that occurs in people who are living in long-term care facilities or have been treated in outpatient clinics, including kidney dialysis centers. Inhalation, aspiration, and hematogenous spread are the three main mechanisms by which bacteria reach the lungs. The development of nasopharyngeal pneumonia represents an imbalance between normal host defenses and the ability of microorganisms to colonize and then invade the lower respiratory tract. Common bacteria involved in nasopharyngeal pneumonia include the following: Pseudomonas aeruginosa, Klebsiella pneumonia, Escherichia coli, Streptococcus marcescens, Acinetobacter, Streptococcus pneumonia, and Haemophilus influenza. HAP clinical picture. HAP are often first suspected with the demonstration of new or worsened radiographic infiltrates, along with other clinical signs of infection, including fever, leukocytosis, and purulent sputum. The clinical must evaluate various findings that are not specific to nasopharyngeal pneumonia, including the following: fever, evaluated white blood cell count, worsening oxygenation, new or worsening pulmonary infiltrate comparable with a bacterial pneumonia, isn't diagnosed based on respiratory secretion cultures. Physical findings is not specific. WBC count may be normal or elevated. The degree of left shift indicates the degree of stress in the host. Traditionally, nasopharyngeal pneumonias have been treated for 14 days. However, ventilator-associated pneumonia can be successfully treated in 7 days. direct empiric coverage against common nosocomial pathogens, Pneumococcus aeruginosa, Klebsiella species, Escherichia coli. Coverage against Pneumococcus aeruginosa also covers other nosocomial pneumonia pathogens. Ventilator-associated pneumonia is a type of HAP that develops more than 48 to 72 hours after endotracheal intubation. Complication of pneumonia: abscess, empyema, pneumonic infusion, common retention of sputum causing lobar collapse, deep vein thrombosis, and pulmonary embolism, pneumothorax, particularly with Staphylococcus aureus, suppurative pneumonia, lung abscess, ARDS, renal failure, multi-organ failure, ectopic abscess formation, hepatitis, pericarditis, myocarditis, meningoencephalitis, pyrexemia due to drug hypersensitivity. Thank you very much for attention.